Ever since Patricia started taking EpiJoint, which has that new ingredient Epitalus in it for mild arthritis, she's got a whole new lease on life. Even discovered a passion for blacksmithery. She makes horseshoes, medieval armour, oh, and her favourite, the mace collection. She's out the back making a ceremonial claymore right now. Yep. She's never been happier.
Good evening, everyone. As part of Musculoskeletal Health Awareness Month, I'm really excited to be joining you tonight to introduce MHA's healthcare professional webinar, Hip Pain, a structured and practical approach for healthcare professionals. My name is Bella Fitzgibbon, and I'm a member of the team here at MHA. I would like to start by acknowledging the traditional owners of all the lands from which we are joining the webinar this evening. On behalf of Musculoskeletal Health Australia, I pay my respects to the traditional owners and custodians of these lands and acknowledge and uphold the traditional owners' continuing relationship to the land and waterways. Before we get started, just some housekeeping. We'll have the chat open throughout the webinar and also the Q&A part of Zoom. Please feel free to put any questions, comments, or any other discussion points, and we'll endeavour to get to all of these at the end of Dr. Armando's presentation. If you have any questions or are seeking any further information or support to assist you in your practice and delivering care to your patients, please also call our Musculoskeletal Health Australia back pain, arthritis, and musculoskeletal condition helpline, which we like to call the BAM helpline. The number is 1-800-263-265. We have a team of highly qualified healthcare professionals on the helpline ready to answer your calls. Now, onto tonight's topic. As someone who lives with severe hip osteoarthritis and has done so since I was very young, I understand firsthand what a struggle this can be. It's not uncommon when we discuss musculoskeletal conditions and arthritis to think that this only affects old people. The truth is, conditions like arthritis, osteoporosis, and chronic pain are incredibly serious and have lifelong impacts on people's overall health and well-being and can impact us at any age. Hip pain especially can be incredibly debilitating and can affect your lives in many ways, personally and also professionally. Understanding as a healthcare professional the impacts of conditions like hip pain and what the best options are for treatment and how to empower your patients to better understand management strategies can make such a huge difference. And that's why we're so excited for tonight's webinar. Our presenter and expert who is going to take us through this important topic is Dr. Armando. He is the creator of Armando Hasudungan Biology and Medicine videos, a free online educational resource that began in 2011. He is also the founder of Visualizing Medicine, a company focused on creating simple, effective medical illustrations and animations. Dr. Armando is currently completing specialty training in rheumatology in Australia, and he's passionate about combining his medicine with education through both online and live presentations. Tonight's session is going to be informative, educational, and incredibly enjoyable. Welcome, Dr. Armando.
Thank you so much, Bella, and thank you, Musculoskeletal Health Australia, for inviting me. I am going to share my screen. So I created this talk focusing mainly for healthcare professionals, but really this is quite a summarized presentation. Maybe it would be a good refresher for some people or revision. And if you are non-health background, hopefully you will learn a thing or two. So without further ado, as Bella mentioned, I guess my name is Armando. I am currently completing my specialization in rheumatology. For those who don't know what rheumatology encompasses, well, we deal with autoimmune diseases and also specific type of arthritis caused when the immune system basically attacks the joints. And here are some images of those types of arthritis we deal with. This is one called psoriatic arthritis, where people with skin psoriasis, this scaly lesion that people can find on their heads or on their scalp or their elbows, can actually lead to or even precede the arthritis. Obviously, we are probably more known for treating conditions like rheumatoid arthritis, and these are patients who has rheumatoid arthritis at different stages. But the one that you see at the end, which is the late stage, this is extremely rare. We don't see this anymore because we have very, very good treatment. And this is obviously this is our bread and butter, and a lot of GPs, bread and butter, which is gout. But we tend to deal very difficult to treat gout or chronic gout or gout that has actual crystals like this. So if you encounter anyone that have any of these and they're not seeing a rheumatologist already, or you're worried, please make sure you get your GP to refer you to us. So today's talk is not about that. It's actually about the hip. And I wanted to just give everyone a refresher about hip anatomy, at least from my perspective, hip pain and differential diagnoses, some clinical pearls, red flags, and towards the end, make it interactive with all of you guys, looking at some cases. So just a general overview, and it was hard getting really good data on hip pain in young adults or just adults, but the amount that has been reported varies. Typically, at least in the physical active adult, some reports say 10%, but really it can go up to 50% in active adults. Whereas in inactive adults, this is probably less. This is essentially saying someone who presents to their doctor with groin or hip pain. The most common cause of chronic hip pain, so persistent hip pain in young adults, is something called femoral acetabular impingement syndrome, or FAI, and acetabular dysplasia, which I will talk about. So, hip anatomy. This is your hip joint. Basically, it's your pelvis connecting to your femur. And as you all know, or some of you might know, the femoral head, this is your femur, it sits in this acetabulum, which is the socket of the pelvis. The femoral head is covered by cartilage. The acetabulum, which is the socket where it sits, I didn't label it here, but it's actually made up of something called a labrum, which is like I wouldn't call it a cushion, but it's sort of like a cushion. It allows the head of the femur to sit nicely tucked into this joint. The hip joint is called a ball and socket joint because it's a ball inside a socket. The shoulder is another type of ball and socket joint, and it allows for a lot of movement, that particular joint. And the hip joint can do many movements. You have flexion, extension, abduction, so moving away from the hip, closer to the hip, something called external and internal rotation, and circumduction. So there is a lot of movement in the hip because we use our hips to walk, to run, to do everything. The hip, obviously sitting in the socket, it needs to be stabilized. One of the stabilizers is this thing called a joint capsule. There's a lot of stuff in this image, but you essentially have to know that the joint capsule, it's composed of two layers. An inner layer called the synovial membrane. And this is important because this synovial membrane produces fluid that sort of, you can say, lubricates the joint. And then the external fibrous layer, which is basically over the synovial membrane. And here I'm just labeling all the parts of the hip joint, which I won't bore you with, but this is an anterior view of the left hip. This is looking from a front view, and this is the posterior view. The joint capsule is one thing, but these are the really strong structures that really hold the hip joint in place. These are your ligaments. You have three important ligaments of the hip joint. These are extracapsular. So I talked about the capsule. Well, this is outside the capsule, extracapsular. And there's three. You have your iliofemoral ligament here, pubofemoral ligament, and ischiofemoral ligament at the back. Why are they called these? Well, it is literally all about anatomy. You have this is your pelvis, this is your ilium, pubis, and ischium. So your iliofemoral ligament connects basically your ilium to your femur, pubofemoral ligament, pubis to femur, and at the back, another ligament, ischiofemoral ligament, ischium to femur. So three important extracapsular ligaments. These ligaments, they sort of move, they spiral when you bend your hip. They actually unwind. So you can imagine when you're standing up, these ligaments are actually slightly twisted. But when you flex your hip, so bringing your knees towards your chest, you're somewhat unwinding this. And you can imagine when you unwind, technically it's less stable because it's not in tension. And I guess that brings me to this, some clinical anatomy called, well, where you get dislocation of the hip joint. Typically, this happens when, well, a scenario is when the hip is actually flexed because your ligaments are unwound a little bit. And obviously, in a car accident, maybe you're driving and then suddenly something happens, obviously, and your basically hip joint becomes dislocated and moves backwards. And again, the reason for this is because the ligaments are relaxed, it's more prone to dislocation. And when your hip is dislocated, not fractured, this is what it would look like. In red, it would be shortened because it's moving back and internally rotated. Moving on, I talked about the extracapsular ligament. So again, these are the ligaments that are around the capsule, around the joint. But you actually have one ligament that's inside the capsule, intracapsular ligament. This ligament here that really connects the femoral head to the acetabulum. It actually carries an artery called the foveal artery, a branch of the obturator artery. This ligament doesn't have as much relevance as compared to the three I spoke about earlier. The blood supply to the hip joint is even more important because the blood supply, as shown here, it branches out of off the artery called the femoral artery, and essentially you get this anastomosis where you have this artery wrapping around the neck of the femur. Why is this clinically relevant? Well, people who get essentially disruption of blood supply can actually cause quite significant damage to the head of the femur. So for example, if you fractured the hip at the neck here, you can actually completely obliterate the blood supply to the femoral head. And this can lead to obviously death of the bone, and really you need to replace it. The nerve supply is also something very important. Looking at it from the front, you have the femoral nerve, and then an obturator nerve. At the back, you have the sciatic nerve. These are the three main nerves that really supply your lower limb. Why is this clinically relevant? Well, there is a common clinical finding where when you have hip pathology, when you actually have a hip joint problem, you can actually get referred pain all the way down to the knee. And this is because they share the same nerve, for example, the femoral nerve, because they have the same nerve sensory supply. The hip pain can actually be referred to the knee. There's a lot of muscles that surround the hip joint. I'm not going to talk about all of them. There are a lot, but these are the ones that I kind of want to tell you guys or educate people on or remind people on. And these are the internal rotators here. and you have essentially two, gluteus minimus and gluteus medius. These muscles essentially connect the pelvis to the head of the femur, and they allow for abduction, but also moving your hip, your leg away from your body, as well as internal rotation. All these other muscles are important for external rotation, your gluteus maximus, but I'm not going to talk to you guys about these. These are the important ones, gluteus medius and minimus, for internal rotation and abduction. So again, this is a clinical, this is an examination finding we assess in clinic for people when people come in with hip pain, but also with any leg pain, to see how strong their basically hip abductors are. So this is normal. When you ask someone to stand on one leg, typically the hip abductors, the medius and minimus, can hold the pelvis straight, as shown here. But a positive Trendelenburg test is when you have weakness in these muscles. And so as a consequence, your pelvis drops. And this tells us essentially that we really need to focus on strengthening these weak abductors, as this can be a consequence of a lot of pain that people get in that affected leg. So that was a really quick crash course on hip anatomy. It wasn't in detail and it was quite superficial, but I hope people have a bit of an understanding about the different structures found in the hip. I didn't even talk about a lot of the tendons and other muscles and these things called bursa, but I will talk about it as we go along and introduce other anatomical concepts. So now let's focus on hip pain. Hip pain, as I mentioned, is very common. More so in the elderly. As people get old, osteoarthritis, as Bella mentioned, is quite common. But hip pain is also common in the young adult. Here is a good example of a cause of hip pain. I mean, you can see already that there's some abnormality in this hip joint on the right side compared to the left. This, I don't have the age of this patient, but this is already quite typical of an osteoarthritic change, where the joint line is very narrow and you can already see some basically whitening of the femoral head and also where the acetabulum is. This is another cause of hip pain, and you can already probably tell where the deformity or the problem is. Straight away, I hope you say it's on the right, but it's a bit different. I mean, you can see this funny whitening and coarseness that's actually affecting the whole femur. If you can see this compared to the left side, it looks pretty different. This is another cause of hip pain, which I'm not going to really talk about, but just so you know all these causes, this is Paget's disease, a very rare bone condition that causes acceleration of osteoarthritis. This is typically seen in the elderly male. And of course, this is another cause of hip pain, but I hope you guys can see the abnormality here. Again, on the right side, but that's a fracture. But, you know, just to illustrate, hip, many causes. I guess this is a very useful way to describe or put in your mind the different causes of hip pain. So hip pain can be thought of as anterior or relating to the groin, lateral, so on the side, or buttock and posterior, so around the bum. I will be actually more focusing on the anterior and lateral causes of hip pain rather than posterior and buttock. Posterior and buttock pain is mainly referred pain from the back or from a condition that we actually treat that affects the sacroiliac joint, which is this joint here, connecting the spine to the pelvis. I just wrote all these differential diagnoses of hip pain, at least how I like to think about it. I spoke about how to describe the hip pain because it can tell you a lot, but these are the differential diagnoses of hip pain. I like to divide it into intra-articular. So what that means is the actual joint, a problem with the joint itself. So femoral acetabular impingement, labral tear osteoarthritis, transient osteoporosis of the hip, avascular necrosis. Extra-articular, meaning outside the hip joint, but relating to that area. And these are the differentials, which again, I will talk about in more detail. These bone stress related essentially are bone causes of hip pain of that region, which includes stress fracture and something called osteoid osteoma, which is not common, but it happens in the young adult and is a benign growth of the bone. And obviously, you have all these other causes. I'm not going to talk about these causes, including infection of the hip or autoimmune causes in this presentation. But it's always important to remember for hip pain, and actually quite a large proportion of hip pain throughout mostly older adults, is referred pain, particularly in the buttock or back. And this is typically from the spine, the lumbar spine, or the sacroiliac joint, which causes the classic buttock pain. Okay, so let's talk about intra-articular causes of hip pain. Intra-articular, as I mentioned, is mainly to do with the actual hip joint, where the femur attaches to the acetabulum. The typical sign people give is groin pain. So they say, my groin hurts. Whenever anyone says this, you got to think about intra-articular causes of hip pain. And they sometimes refer to the C sign, where they basically cusp their hip region. And this is also a very good indicator of intra-articular causes of hip problems. Typically, when you examine the hip itself, it's actually painful and often restricted. It's very poorly localized because it's deep inside. And there's a lot of tests that you can do to make it worse, which I'll talk about. Again, because it's inside the hip, the actual joint, it can radiate down the thigh to the knee, as I've explained. Extra-articular cause of hip pain is more superficial. It can be at the side, lateral, or posterior. It typically doesn't cause an issue in hip movement unless you're really going at full range when you assess the hip joint. There's usually superficial or localized tenderness because it's outside the hip joint. You can actually pinpoint the tenderness or the pain area. And again, it may also radiate down the leg like the intra-articular problem. So the first cause that I wanted to talk about, and the most common in a young adult, is femoral acetabular impingement. Typically, what people describe is gradual onset, deep groin pain that is worse when you flex the hip and perform internal rotation, something called the Fadia test, which I will show. Interestingly, this femoral acetabular impingement is more often in active individuals. And really, this problem can and is often associated with labral tears and secondary osteoarthritis if untreated. So this is what's called the Fadia test. Patient lies, and this is their affected hip. You're flexing the hip as shown. You're actually what's called adducting, bringing the hip joint midline, and you're doing internal rotation. And you're really putting a lot of strain on the hip joint. And this will reproduce, most definitely, FAI. So this is a illustration of what FAI is, femoral acetabular impingement. This is a normal hip joint. In FAI, there are two main types. There's something called a CAM lesion in FAI, or a pincer lesion. And these are essentially bony overgrowths. This is what femoral acetabular impingement is. Essentially, you get this bony overgrowth either near the femoral head or a pincer growth. And essentially, when you move it, you can imagine you're actually irritating it and you're causing pain. So in that maneuver where you flex the hip and do the internal rotation, you're essentially causing this to happen and causing pain. This is an X-ray of someone with femoral acetabular impingement. You can see already, if you can recall, but see this bump here? That's a cam lesion. That's not meant to be there. It's meant to be more smooth and then becomes a ball rather than this growth here. It's actually on this side too, but to a lesser extent. So this is an example of bilateral femoral acetabular impingement from a cam lesion. Then I did mention labral tears, which are associated with femoral acetabular impingement, as well as with osteoarthritis. It's really hard to differentiate, but again, it's the deep groin pain, and it can be associated with clicking, locking, or catching when you move the hip itself. So as I mentioned, the labrum is typically this socket where the femoral head sits nicely. It's in the acetabulum. A labral tear is when you have a tear of that labrum. And again, labral tears are associated with the FAI and osteoarthritis. And this, I'm trying to depict osteoarthritis here, but you get a bit of joint space narrowing. This is a MRI of with contrast looking at the labrum, and this is all this white here is a labrum, but you can see a bit of abnormality here, and these are all tears within the actual labrum. The other very common cause of chronic hip pain in a young adult is acetabular dysplasia. Essentially, in this condition, you have what's called a shallow acetabulum. The acetabulum is quite shallow, and this leads to instability and also possibly subluxation or dislocation. You get groin pain, early OA, if obviously, if it is present since birth. Typically, acetabular dysplasia, it can arise when you're a young adult, but typically it follows through from when kids have issues with their hips already. There is a condition called congenital hip dysplasia, where people have to actually wear this harness when they're a baby, and eventually they become okay, but unfortunately the hip can remain a problem as they get older. So just to diagrammatically show it, normal hip joint, this is a shallow acetabulum where the acetabulum, where the femoral head sits, is shallow. And so that is prone to instability and obviously subluxation or even dislocation. This is quite a prominent sort of acetabular dysplasia problem in a young adult, but this person most definitely had problems in infancy that has then led to this, which, as you can see, really shallow acetabulum, but also deformed femoral head. The next cause of intra-articular hip pain is something called transient osteoporosis. This is when people get sudden onset, what's called bone marrow edema and osteopenia of the head of the femur on the MRI. What bone marrow edema means is basically when fluid enters the bone and you see this sort of shiny thing on the MRI. That's called bone marrow edema. Typically, it affects men between the ages of 30-50, but you have to think of if someone presents with this sort of hip pain, you got to think about especially women in pregnancy. This can also occur, or postpartum. They often present with groin pain again. It can be quite sudden and often severe. It worsens with weight bearing. They may limp or need crutches, but otherwise they have no other symptoms. They have no fevers. With this particular problem, it often resolves after 6 to 12 months without any progression to something called avascular necrosis or AVN. Now, You might be thinking, does this mean osteoporosis, where you actually have weak, bones? Well, not really. It's quite a different entity, actually. So osteoporosis, if you MRI them, I mean, it's practically normal. Like, you don't see anything. Osteoporosis is not painful. Osteoporosis is where you have your bone minerals are, your bone density is weaker and you're more prone to fracture. Transient osteoporosis is different because what you get on MRI is you see this buildup of pressure. You can even say inflammation, but it's not correct. It's not correct inflammation, but you get a lot of pressure and irritation of the femoral head, leading to this reduced bone mineral density, but also a lot of pain. So this is what it looks like on MRI. You can see this white. This is all bone edema. This is painful, whereas on the right side, it's normal. So this typically resolves after 6 to 12 months of therapy, but you need to non-weight bear. You gotta make sure it doesn't get worse and really monitor it carefully. Avascular necrosis is a quite important differential to remember as for an intra-articular cause of hip pain. It's basically where you get ischemia or death of the femoral head, and that can lead to something called collapse, which is basically when the femoral head just breaks down. It presents with groin pain, often very gradual, very gradual. People just feel a niggle and it sort of gets worse and worse and worse. It is associated with high dose corticosteroid use. So steroid use, alcohol, quite significant alcohol, and anything that predisposes someone to develop a clot. So any condition that does that, including cancer. Typically, you diagnose it with an MRI because that's the earliest finding you can see for avascular necrosis. Is the same as transient osteoporosis, which is bone edema, and X-ray may be normal initially, but it can progress. Sorry, this is a lot of information, but there's a way to classify avascular necrosis, and many classification systems. This is one of them, but you can see I've sort of tried to illustrate the progression from stage 1 to stage 4 of what looks to be a normal hip on radiograph, on X-ray, so slowly progresses and it leads to collapsing, basically, where you can see it's breaking down the femoral head and really accelerates osteoarthritis. On MRI, you can see different findings, which I won't talk about, but bone marrow edema is the earliest one you can see. And so this is what it would look like. This is someone who has bilateral or both avascular necrosis, so basically death or reduced blood supply to the femoral head. You can see, at least in this one, you can see there's bone marrow edema, like in the other condition, but you can see the femoral head. It's not symmetrical, like it's irregular. That's because it's collapsed. It's collapsing. It's breaking down. Similarly here, you can see breaking down as well without any significant inflammation. This is an X-ray of someone with avascular necrosis. Again, you can see, probably you can look at this and think it's osteoarthritis, but really it's the head of the femur is way too irregular, and you get all these funny circles around the femoral head. This is avascular necrosis. So that was a quick rundown of intra-articular causes. How about extra-articular causes? Well, extra-articular causes are basically everything to do outside the hip joint, and they could be caused by tendons, muscles, or even the bursa. These are the fluid sacs that sort of help with movement of the hip joint. So this is, I didn't draw everything because there's a lot of structures, but I just wanted to highlight some really important ones around the hip joint. This is your right hip. You've got the gluteus medius. Remember that muscle I talked about that's important with internal rotation and abduction, where this muscle originates from your bum and it comes down and it enters in the sort of the outer part of your femur, which you can actually feel on yourself. And in front of it, you have something called the tensor fascia latae, which connects to your other bum muscle called the gluteus maximus, and it forms basically the iliotibial band that runs down to your knee. This is also a very important structure to know. This muscle here that is highlighted in quite light is the iliopsoas. It's composed of the iliacus and the psoas muscle that comes and connects down, that comes from the lumbar spine, which is your lower back, and also your pelvis, comes all the way down and connects here. The reason why I'm illustrating this is because it relates to some extra-articular causes of hip pain. And also these bursas, which are again the fluid sacs that can also get irritated and also can cause hip pain. So a very common cause of hip pain, at least lateral hip pain on the outside, is gluteal bursitis and tendinopathy. It's typically always together. When you get bursitis, you're going to get tendinopathy, irritation of the tendon. It's lateral hip pain and it's point tenderness over the region called the greater trochanter. It's worse when you lie on the affected side, and there's a lot of tests you can do to aggravate it. And I will show you one of them. Basically, this is where the patient, you can say, has pain on his left side, and he's abducting his hip, and he's trying to hold there against resistance as the clinician pushes it down. If someone has a bursitis or tendinopathy of the greater trochanter in that area, that's going to reproduce the pain. So this is greater trochanteric pain syndrome, where you basically have the gluteus medius that connects to that area. It's irritated, but also the surrounding bursa there is also irritated. It's painful. It's painful to lie on that side. It's a very, very, very common cause of hip pain on the lateral side, especially if you have altered biomechanics for whatever reason. And again, pinpoint tenderness, and you can even, a lot of allied health team know how to manage this and treat this, but really strengthening the area, taking anti-inflammatories. Then there is this other entity called iliopsoas tendinopathy. This is actually quite difficult to diagnose, and it's not common. Essentially, it's inflammation of the iliopsoas tendon, which I'll show you again, presenting with deep anterior groin pain, and may present with something called snapping. The pain is worse with hip flexion, and the reason is because this muscle is responsible for flexing the hip. So you get pain when you walk upstairs, rising up the chair. Also pain obviously with resisted hip flexion, but also with passive hip extension. So again, the iliopsoas muscle is made up of the psoas major and iliacus. It comes down and connects to the femur here. Iliopsoas tendinopathy is when you have inflammation of that tendon. So the pain typically comes when you flex the hip, because these muscles is responsible for, one of the muscles responsible for hip flexion. And so when you perform hip flexion, you're essentially irritating the hip even more. And so that's why you have pain on hip flexion. This leads me to snapping hip syndrome, something that I haven't really come across personally. And I think this is more sports physicians and physiotherapists or exercise physiologists. But snapping hip syndrome is basically when a tendon around the hip region snaps over some bony prominence. And the typical tendons are tendons from the iliopsoas, which I talked about, and the gluteus maximus or medius. So what happens is you hear this audible, palpable snap, which can be painless or painful. Often benign, but can be associated with bursitis, which is inflammation of the bursa. So remember this diagram, you have the psoas major, iliacus, iliopsoas tendon inserting into the hip, which can be inflamed. Well, the same muscle and tendon can actually cause a snap as it moves over this bursa, over this bony prominence around the pelvis. And this snapping can be attributed to the bursitis, but mainly because it moves over the bony prominence in this region. And typically the snap occurs, again, there's a lot of detail, when you extend the hip from flexion and abduction. This snapping hip syndrome is what's called the internal type, because with the internal type, there's also the external type. The external type is when you have basically the tendon, which is this ITB or the tensor fascia latae, that snaps over the greater trochanter, which is that region here. And the snapping essentially occurs when you move the hip from flexion to extension while they're adducted. Now, this you can definitely feel when you examine the patient. So let's have a look. So this person is examining a patient for snapping hip syndrome internal, so the iliopsoas tendon. You can see in A, this person's actually in a flexed position initially, and his hip is abducted. But then when the hip becomes extended, that's when you feel, or they can feel, the snap. This one is when they're assessing for the greater trochanter. So the hip is being flexed and extended, and the clinician can actually feel this one, and it can feel the snap. And this can be obviously associated with the greater trochanteric pain syndrome. Just quickly, bone-related pathologies of hip pain. Stress fractures, we all think about, especially with a young adult that is very active. It's an overuse injury from repetitive loading. So typically, very competitive sports, or someone that's just started all of a sudden really doing a lot of activity more out of the ordinary. But we typically see this in athletes, or really, people that exercise a lot. But remember, there are two main types of stress fractures in the hip region. This is the tension and compression. Tension is the most important because this really needs an orthopedic review, a surgical review. So these are the two types. You have the tension fracture, where you have it in the superior part of the femoral head, or the outer, and the compression fracture, which is inferior, or the inner. The reason why they're called this is because of the force that's applied from your body. Essentially, this force that goes down onto your hip causes a tension fracture to be very dangerous, because it can lead to a worse, or basically a bigger fracture. Whereas a compression fracture, it sort of keeps the fracture sort of tight, so less of a risk. And typically, this is not a surgical problem. So, clinical pearls. A negative Fadia test, so if you remember, that's flexion, adduction, and internal rotation, that we typically use to assess for femoral acetabular impingement. If it's negative, if you do this test and it's negative, it kind of makes like a proper intra-articular hip pain less likely. So you always want to do hip internal rotation. Remember that. Again, if someone presents with medial knee pain with a normal knee exam, or knee pain in general with a normal knee exam, think of hip pathology because of that referred pain. Lateral hip pain, that's especially tender, is almost never intra-articular. Initial management for any young adult with hip pain should include just anti-inflammatories for a certain duration, activity modification, and if it persists, an X-ray. You should refer to a specialist, whether it's a sports physician, orthopedics, or rheumatologist, if you have a chronic hip pain, despite management, or even if they have normal imaging and you need some guidance and it's out of the ordinary. These are red flags. So obviously an infected joint is a red flag, a stress fracture, but mainly if it's a tension fracture on the top. Avascular necrosis, if you suspect someone who has this, or actually who has an MRI of this, you really want to get them assessed quite urgently. Malignancy, obviously, or unexplained night pain. So all of these definitely, if you're concerned, require some form of imaging more than an X-ray. Okay, I think I'm doing okay with time. I know I'm going pretty slow, but this next one will be pretty speedy. Let's talk about some clinical cases. And I hope that there are a few allied health workers here. Um, so, 28-year-old soccer player, gradual onset of hip pain, 6 to 12 months. They describe it as a deep groin pain, and they have the C sign. Worse with certain maneuvers, occasionally clicking and catching, improves with rest, partial relief with anti-inflammatories. No real history of trauma, otherwise quite well with no fevers, weight loss, and whatnot. He had pain with the Fadia test, so flexion, adduction, internal rotation. His internal rotation is slightly reduced. There's clicking and catching during the actual examination. He had no other he had no neurological abnormalities or vascular abnormalities on examination. So I just want to see if people were listening. If you can scan the QR code with your phone, for those who have one, and you can select your answer. This is called reinforcement. And I can see I can see there's 0 participants. Oh, there's one. Perfect. I at least want to see a few. So I'll wait for a bit longer, see if we can get a couple more. So there'll be a few more of these. You just have to refresh. You don't have to keep scanning the QR code. You just refresh the page on your phone. Okay, let's see how you guys did. No one else? We'll leave it at okay, good, good. So this is a young guy, sport, 6 to 12 months, C sign, Fadia test was positive and some catching. And this is X-ray. Correct. It's cam pincer. So that was a trick question because you can't actually see a labral tear on X-ray. I'm sorry. You got to use an MRI for a labral tear. But this person most definitely probably has one. So you would see a cam pincer morphology on X-ray. You would see the abnormal X-ray as I showed earlier. Okay, next one. 35-year-old woman, postpartum, so after pregnancy, really developed quite sudden pain in the hip that sort of progressed after several months and quite severe, worsens with weight bearing, limp, pain minimal, at rest, otherwise really well, and no preceding trauma. When you examine her, she's limping, antalgic gait. She's got pain. Basically, you examine her hip. There's pain everywhere because it's just when you examine it in any movement. There's no swelling. There's no redness. On X-ray, you noted that she has something called diffuse osteopenia. Normal sacroiliac joints, no fractures. So diffuse osteopenia means the bone looks a bit more less dense, I guess you could say. So just you can refresh your phone. So we had 7 last time. Let's try to get 7 again. Even more would be great. Oh, perfect. Great. So what do you think is the diagnosis? So this is a bit of a tricky one. Fantastic. Awesome. Which finding best differentiates transient osteoporosis of the hip from avascular necrosis of the hip? All right. No one else? Okay, awesome. So what differentiates transient osteoporosis of the hip to avascular necrosis of the hip? Excellent. Yes. So, well, the pain will worsen with weight bearing with both of them. Both occur in young adults, middle-aged adults. It is associated with groin pain because it's intra-articular. Remember, groin pain, it's usually always intra-articular. But yeah, the difference is both have bone marrow edema, but one, which is avascular necrosis, you get collapse, which is breaking down of that femoral head because it's the blood supply is lost. And yeah. Okay, so let's look at this story. I think this might be the last one or second last one. 40-year-old male, really quite insidious onset of pain in the hip, one of the hips, a dull groin ache radiating to the thigh and buttock, worse with walking, standing, initially relieved by rest, but now it's like there all the time, even at night. He's been on steroids for rheumatoid arthritis, quite high doses as well. Enjoys drinking, no fevers, systemic symptoms. On examination, he was relatively overweight, pain with hip flexion and internal rotation, limited range of movement. He was limping the whole time. He otherwise was like he had no fevers or no other abnormalities on examination. All right, let's see how we went. So, I mean, I should I should say, what is your provisional diagnosis? What do you think is going on? That's correct. The giveaway is someone this person is a well, he drinks more than average, and also he's on long-term steroids. I should say high dose steroids, to be honest. But yeah, so I think if someone presents with kind of new onset hip pain out of the blue and they've been on steroids long term, high doses or recently or something, um, or they've got risk factors like clotting, tendency to clot, and there's many causes, or chronic alcoholic, for example. You've got to be, it's rare, but you have to think about it, especially if it persists, and especially if it's there when you rest, if it gets worse and it's there when you rest. So you got to investigate. And it's a immediate referral to the orthopedic doctor. Oh, okay. I hope this is going to be 100%. All right, let's have a look. Awesome. Yeah. Oh, it's one of the two, but it's actually steroids are the biggest risk factor. Steroids, steroids, steroids. Oh, sorry. One more. One more. All right. This person, gradual onset hip pain during marathon training. It's in the groin, it radiates to the thigh. It's mainly when they do stuff. But it does go to the night as well, but it becomes really bad when they run, and perform activities. Um, Initially relieved with rest, but now it's persistent, otherwise completely well. So you examine them, pain on hopping on a single leg stance, really tender over the femoral neck, or when you palpate, really focal tenderness. um, really limping, and it's when you examine, it's limited. It's limited by pain. X-ray was normal. MRI shows a fracture line, edema of the superior aspect of the femoral head, normal inflammatory markers. So this is surgery. And by no means am I a surgeon, but my understanding it's yes, stress, yeah, shaft, yes, you do, depending on where. Sorry, I didn't elaborate. But if it's part of the shaft that you're not worried about, you don't need to have urgent surgery, but it's definitely tension side. So you have a tension side shaft fracture, that's also urgent surgery. So any tension related stress fracture needs a immediate orthopedic review. But I guess all of these need an orthopedic review as well. But surgery, tension. These are the references I've used for my talk, and very good reading material if you are interested in learning more about hip pain in a young adult. But yes, I'm open for questions if there are any, or yeah.
That was an incredible presentation. Thank you, Dr. Armando. Quiz at the end, I fared a bit better than I thought I was going to go as a non-clinician. So thank you for putting that in. We will have the recording of this webinar up on our YouTube in the coming days. There was a lot of different conditions and information on there, but with the visuals, really helped us to get a greater understanding of that. So you'll be able to go back and reflect on the different slides and keep investigating these different conditions. So thank you, Dr. Armando, for that. Just before I let you all go and enjoy your evening, I just want to bring to your attention a little event we are doing this Sunday. What we like to say is that sit happens, especially when you are breaking a world record. So this Sunday, the 26th of October, Musculoskeletal Health Australia needs you to sit and get moving for the world's biggest sit-in. This is our attempt at MHA to break a world record for the largest 30-minute chair-based exercise workout ever held. And we need you all to take part, please. The event is held in person at Ripponlea Estate in Melbourne. We have our incredible WBSI ambassador Luke Hines leading the workout, and we have our MAM ambassador Gerald Quigley on stage as well, taking part in the workout. There will be coffee, gelato, and other stores to interact with that also have giveaways that are good for you, your patients, and your musculoskeletal health. So please join us on the 26th of October. Register at wbsi.org.au or scan the QR code on the screen. I just want to finish by thanking you all for joining us tonight. A huge thank you again to Dr. Armando. And don't forget the last event in what has been an amazing Musculoskeletal Health Awareness Month is the Coadlo Lecture. This will be live streamed next Tuesday evening, 28th of October at 7 p.m. and presented by our amazing Musculoskeletal Health Awareness Month Ambassador Gerald Quigley. His oration on the topic, Movement is Medicine. So on behalf of MHA, get sitting, get moving, and we'll see you all on Tuesday evening. And thank you again, Dr. Armando.